It is my pleasure to welcome you to this in-depth lecture, the second part of the 7th e-ESRA Congress International Edition, where we will delve into the anatomy and sonography of the lumbar spine. Each vertebra is made up of a body and arch. The arch is composed of two pedicles, a spinous process, two laminae, two superior and inferior articular processes, and two transverse processes. The vertebral canal is formed by the spinous process and lamina posteriorly, pedicles laterally, and vertebral bodies interiorly. Within the vertebral canal lie the thecal sac and its contents. In this three-dimensional image, we can observe the different components of a lumbar vertebra. Spinous process, transverse processes, laminas, body, and articular processes. The lumbar vertebral bodies are large and robust. Designed to support most of the body's weight, they have an oval or reniform, kidney-shaped appearance in the superior view. The spinous processes are broad, short, thick, and rectangular. These project horizontally without descending, allowing for greater mobility in flexion and extension. The transverse processes, costiform processes, are long and slender, referred to as costiform because they represent vestigial rib remnants. At the lumbar level, the facet joint line is predominantly oriented in the sagittal plane. The superior articular facets are directed medially and posteriorly. The inferior articular facets are oriented laterally and anteriorly. When observing a lumbar vertebra from its inferior aspect, we can identify the vertebral body, pedicles, spinal canal, transverse processes, inferior articular processes, laminae, and spinous process. There is a group of muscles that insert into and surround all the vertebrae of the lumbar region. Posteriorly, the multifidus, longissimus, and iliocostalis muscles provide support and stability. Laterally, the quadratus lumborum plays a key role in lateral flexion and stabilization. Anteriorly, the psoas major and iliacus, forming the iliopsoas, contribute to lumbar and hip movement. Here is a group of muscles that insert into and surround all the vertebrae of the lumbar region. The discs are located between the vertebral bodies and are responsible for absorbing 80% of the body's weight under normal conditions. The spinal nerves emerge through the intervertebral foramina and divide into a ventral ramus and a dorsal ramus. The ventral ramus, by joining adjacent branches, contributes to the formation of the lumbosacral plexus. Meanwhile, the dorsal ramus extends posteriorly, passing beneath the mamillo-accessory ligament, where they divide into a medial and a lateral branch. In the lower vertebrae of the spine, a third branch, known as the intermediate branch, may also be present. The medial branch is responsible for innervating the bony structures of the posterior arch, including the facet joints. The other branches have exclusively motor and sensory functions, providing sensation to the skin in the most medial part of the back. The posterior vertebral arch consists of the laminae, pedicles, spinous processes, transverse processes, and articular processes. Its innervation comes from the medial branches of the posterior rami of the lumbar spinal nerves, which innervate the facet, zygapophyseal joints, the interspinous ligaments, the ligamentum flavum, and the paravertebral muscles. The sinuvertebral nerves of Luschka re-enter the vertebral canal and contribute to the innervation of the spinal dura mater and posterior ligaments. The vertebral body and disc are primarily innervated by the sinuvertebral nerves of Luschka, which arise from the gray communicating branch of the spinal nerve and re-enter the vertebral canal to innervate the periosteum, the posterior longitudinal ligament, and the intervertebral discs, and branches of the sympathetic plexus, which provide autonomic innervation to the blood vessels supplying the vertebral bodies and intervertebral discs. These nerves carry both sensory information, pain and proprioception, and autonomic signals, vasomotor control, and play a crucial role in transmitting lumbar pain of vertebral and discogenic origin. Each medial branch of a lumbar spinal nerve emerges from the posterior ramus of the spinal nerve just after the nerve divides into anterior and posterior branches, wraps around the articular process and the intertransverse ligament before reaching the facet joint. It divides into ascending and descending fibers, resulting in a dual innervation pattern for each facet joint. Each lumbar facet joint receives innervation from the medial branch of the spinal nerve at the corresponding level, and the medial branch of the spinal nerve from the level immediately above. For example, the L4-L5 facet joint is innervated by the medial branch of the L3 spinal nerve ascending and the medial branch of the L4 spinal nerve descending. Unlike the dorsal branches of L1 to L4, which do divide into medial and lateral branches, the dorsal branch of L5 does not exhibit this classic differentiation. Its course is shorter and is limited by the orientation and proximity of the sacrum. We will describe the examination axes at the lumbar level, specifically the axial and sagittal axes. The transverse plane, also known as the axial or horizontal plane, is parallel to the ground and divides the body into superior and inferior sections. For an axial examination of the lumbar spine, when placing the transducer over any spinous process and lamina, with the patient seated or in a lateral position, the spinous process appears as a sharp, hyperechoic reflection beneath the skin and subcutaneous tissue, continuing with the acoustic shadow of the lamina, which completely obscures the underlying spinal canal and consequently the neuroaxial structures. Therefore, this view is not ideal for imaging neuroaxial structures, but is useful for identifying the midline when the spinous processes cannot be palpated, such as in obesity or individuals with significant edema. This point corresponds to the lower part of the lumbar vertebra and will be defined as the laminar pattern. If the transducer is placed between two spinous processes, we will observe that the ultrasound waves can pass through a structure with lower echogenicity than the surrounding muscle. This structure corresponds to the supraspinous and interspinous ligaments. Deeper, a more posterior and less reflective line, which we will refer to as the posterior complex, corresponds to the junction of the ligamentum flavum and dura mater. Due to its cylindrical shape and the convergence of ultrasound beams from the curvilinear probe, it appears as a horizontal line. At a deeper level, we will see a much more reflective and brighter line, which corresponds to the posterior dura mater, posterior longitudinal ligament, and vertebral body. This line is called the anterior complex. Additionally, besides identifying an acoustic gap that allows us to locate and access the neuroaxis, we can also identify the articular processes and, in some cases, the facet joints and transverse processes. We will call this pattern the interspinous pattern. The interspinous pattern, according to some authors, has a certain resemblance to a bat. As we slide the transducer in a cephalad direction along the lumbar spine, a rhythmic and almost repetitive pattern emerges before us, alternating between the two previously described sonographic views, the interspinous pattern and the laminar pattern. In the interspinous pattern, an acoustic window opens that allows us to visualize the contents of the vertebral canal, including the anterior and posterior complexes, as well as the cauda equina. With a slight further cephalad movement of the transducer, the image transitions into the laminar pattern, characterized by hyperechoic laminae with posterior acoustic shadowing, structures that are more superficial and delineated. The axial interspinous pattern in ultrasound imaging is likely the most informative of the two projections. In this axial interspinous pattern, the spinal canal is delineated by two parallel hyperechoic lines. The superficial line represents the ligamentum flavum dura mater complex, posterior complex, while the deeper line corresponds to the posterior complex. The epidural space is considered a virtual space, surrounded by structures such as the ligamentum flavum and dura mater. This can hinder ultrasound penetration and result in poorly defined images in this axis. Cephalad and caudal tilting of the transducer should be applied to optimize visualization of the ligamentum flavum dura mater complex. Furthermore, using a curvilinear probe in an axial examination generates convergent ultrasound beams that may result in loss of definition at the peripheral regions when encountering a cylindrical structure. Ultimately, while this approach can provide an estimate of depth, it does not allow for clear identification of the epidural space in this plane of examination. The deep hyperechoic line, which is more refringent and parallel to the posterior complex, is referred to as the anterior complex. This structure represents the combined ultrasound image of the anterior dura mater, posterior longitudinal ligament, and vertebral body. Additionally, this examination plane enables the identification of facet joints and transverse processes. which can serve as anatomical landmarks to locate and target the medial branch as it traverses the neck of the articular process for interventional procedures. The examination in the sagittal or longitudinal axis divides the body into a right and a left half and will allow us to identify 4 patterns. If we place our transducer in a sagittal or longitudinal axis, starting from the midline or interspinous line, we will identify a pattern that we call a mountainous saw pattern. Acoustic shadows originate very superficially and completely obscure the deeper structures. The spinous processes will only be visible in patients with some adipose panniculus, since in thin patients, the spinous processes will protrude over the skin, creating air bubbles between one spinous process and the next, which artifacts the image. As the transducer moves laterally from the midline, paramedian sagittal axis, the laminae become visible. These laminae appear as hyperechoic images resembling horse heads or a series of waves, layered one on top of the other. Between each lamina and the acoustic shadow it produces, the spinal canal can be identified, along with the posterior and anterior complexes, which become more evident when a slight medial oblique tilt of the transducer is applied, oblique paramedian sagittal axis. Slightly lateral, as the transducer is positioned longitudinally over the facet joints, a series of rhythmic wave-like or mound-like structures will appear on the screen along the longitudinal axis. These images resemble the humps of a camel, with the facet joint line identifiable at the highest peak of each mound. Over the transverse processes, 3 consecutive transverse processes resemble a trident, composed of hyperechoic curvilinear structures with finger-like acoustic shadowing. Spinous processes, Montaigne sign. Laminae horse head sign. Facet joints, camel hump sign. Transverse process, trident sign. The paramedian sagittal scan is the most commonly used approach for visualizing neuroaxial structures. Neural structure visualization can be enhanced by applying a slight medial tilt to the transducer, known as the oblique paramedian sagittal plane. During the scan, the transducer is placed 2 to 3 centimeters lateral to the midline paramedian over the laminae in the sagittal axis and angled slightly medially toward the midline. The purpose of this medial tilt is to ensure that the ultrasound beam enters the spinal canal through the widest part of the interlaminar space rather than through the lateral recess of the canal. Between the dark acoustic shadows of the adjacent laminae, there is a rectangular area on the sonogram where neuroaxial structures can be visualized. This is an acoustic window created by the reflection of the ultrasound signal from neuroaxial structures within the spinal canal. The ligamentum flavum also appears hyperechoic and is often seen as a thick band across 2 adjacent laminae. The posterior dura mater is the next hyperechoic structure anterior to the ligamentum flavum, and the epidural space is the hyperechoic area, a few millimeters wide, between the ligamentum flavum and the posterior dura. The thecal sac, filled with cerebrospinal fluid, is the anechoic space anterior to the posterior dura mater. The cauda equina, located within the thecal sac, often appears as multiple horizontal hyperechoic shadows within the anechoic sac, and its position can vary with patient posture. In some patients, pulsations of the cauda equina can also be seen. The anterior dura mater is also hyperechoic, but is often difficult to differentiate from the posterior longitudinal ligament and the vertebral body or intervertebral disc, as they have the same echogenicity, isoequic, and are tightly adhered. This often results in a single anterior composite hyperechoic reflection, commonly referred to as the anterior complex,